Corona strategies. And we are so pleased to have three speakers today who are going to help shed some light on what is going on at the state and local level related to vaccine distribution. This is the second in a series of webinars that Sirona is holding about vaccine distribution. The first one was about the CDC playbook, and that is recorded on our website under news. So you can find it there. We also had a conversation with ASTO on that first webinar. We outlined the CDC playbook, and now we actually have a little bit more information about what state and local jurisdictions did with that playbook. The plans were due on Friday, and we are collecting those plans and have developed a tracker. So if you're interested in the tracker, we'll be updating it on a daily basis as we get those plans. So without further ado, I'd like to introduce Kate Johnson, who is with the National Governors Association Center for Best Practices. She's a program director there and helps governors' offices on a variety of issues. And she is in charge of the vaccine segment over at NGA. Prior to NGA, she was a consultant at a public affairs firm. And she also worked as an aide for Senator Joe Lieberman from Connecticut and at Beth Israel Deaconess Medical Center in Boston. And we're very happy to have you, Kate, so I'll let you take it away.
Great, thanks, Krista. And thanks everyone for having me. Happy to be here to be able to provide just some kind of overarching perspectives of the work states have been engaged on around vaccine planning. And it's great that we have state and local folks who can expand upon what they're currently engaged in. As Krista mentioned, my name is Kate Johnson, and I'm a program director at the National Governors Association, specifically in our Center for Best Practices. And for those who may not be familiar with NGA, there are sort of two sides to the organization per se. Our more traditional government relations side that lobbies on behalf of governors to the Hill and the administration and really serves as their collective voice. And then the Center for Best Practices, where I work, which really operates more as kind of a think tank consultancy for states. And we work with states and governors' offices on specific projects and policy areas under their purview. And I, of course, focus on health. And as Krista mentioned, have been leading in collaboration with folks across the organization, our vaccine work related to COVID. I also work on aging and data issues. And so just a little bit of background on how we've been supporting states recently. We've really been focused on kind of getting information that's needed out to states. So we've held a series of briefings with particular focus on bringing in administration officials from Operation Warp Speed and CDC and FDA to really kind of update state folks on what's happening with regard to federal strategy and planning as information becomes available. In addition to that, we held a meeting on September 25th for states and territories. We actually had 37 states and territories participate in that meeting, and that was hosted in collaboration with the National Conference of State Legislatures. So we had legislators, we had governors, advisors, health department staff, and the like, all together to really talk about some of the key planning issues and sort of what remains in terms of challenges for vaccine planning. And that was both with regard to COVID-19 vaccines, but also, thinking about seasonal flu and childhood immunizations and how all of that fits together in the state. And so I'll share a little bit more about takeaways from that meeting and what's sort of really in focus for states based on that engagement. We've also been coordinating with partner organizations, including ASTO, which I know many of you heard from in a previous webinar, the Association for Immunization Managers and others, to really provide coordinated support for states, and of course, engaging with the federal government as well. And so, as I think many of you heard, the CDC released their playbook back on September 16th. And really a lot of what states have been planning is kind of reliant on, understanding federal strategy and actively coordinating with the federal government as their plans roll out, and states are working on developing theirs. So that playbook was really pivotal, and states had a month to submit those plans, which, as mentioned, were submitted on Friday, and we at NGA are still similarly kind of digesting the plans that have been made public and tracking those over the coming week. But I think, states are making individual decisions about if, how, and when they'll release those plans publicly. Not all necessarily will, or they may do it in a variety of ways. And we're really thinking about how we, in collaboration with other partner organizations, can do sort of a crosswalk and analysis of those plans in the coming weeks. But an important thing to note from my perspective and our perspective at NGA, based on conversations with states, is really that the plans themselves are going to be updated over time. So it's really an iterative process. So what's submitted on Friday will likely change in the coming weeks, and additional details will be added. And both the feds and states have an understanding that this is kind of what the process will look like going forward. Also important to note, which may have come up on your last conversation, the CDC has been actively engaged with 5 pilot sites, 4 states and 1 city, specifically North Dakota, Florida, California, Minnesota, and Philadelphia, on kind of micro planning efforts. And that those efforts have informed not only the development of the playbook, but will continue to form kind of the iterative process with states going forward. And I'll just share a few, I think, takeaways from those planning efforts, which really mirror what we heard from our meeting on September 25th as well, with states and territories, and then get into, what we've heard from states as really kind of key remaining questions across the planning areas. So I think early planning efforts in coordination with the feds have revealed a few key things. One being, these are really resource intensive efforts, and that states, are really needing additional resources for both planning and implementation in terms of COVID-19 vaccines, as well as seasonal flu. That came across loud and clear in our meeting on the 25th, and continues to be something on our government relations side that we are pushing for. And that's to support, not only sort of the broad array of planning activities, but also, staff capacity in the states. There's a real continued need for transparent communication from the federal government. And I think there are some key information gaps that remain that states are really eager to get more information on quickly. So that's an ongoing need. Technology, data, IT infrastructure really remains a persistent challenge. And I'll talk a little bit more about some of the key questions there in a moment. And then public confidence in vaccines. I think the biggest takeaway from our meeting with states on the 25th was around, the sort of uptick in vaccine hesitancy, distrust in government, and the politicization of the process, and how states are planning to communicate, identify trusted messengers, reach, specific communities in ways that are effective. All of that is really top of mind for states, and something that remains a challenge. So, and then lastly, I'd say probably another big takeaway from the micro planning efforts is around allocation, and that, any sort of allocation formula coming from the Fed should really consider additional factors beyond simply the population size in the state. I think to date, we've only really heard, that there will be a sort of population-based formula from the feds. And I think there's a real note from states that there should be additional considerations in any formula that's developed. So those are some early learnings, and I think I'll just quickly walk through across the planning areas some remaining questions. I mentioned allocation. That is a key piece, and what remains to be sort of outlined by the feds is top of mind for states. And it will be really important in figuring out how states are kind of within their own jurisdiction allocating to prioritize populations when there are really limited doses initially. So that is one remaining question in the area of allocation. And with regard to prioritizing populations, I think the federal government's working on their priority phases. The National Academies released their final framework in early October. The Advisory Committee on Immunization Practices at CDC is also, being informed by the National Academies and simultaneously working on, their phased categories. What seems to be clear is, that healthcare personnel, healthcare workers will really be kind of top of the list. And there are some discrepancies, I think, across the academies and ACIP with regard to what falls into phase 1A versus phase 1B. But other essential workers, high-risk individuals, adults over 65 are the other kind of categories that fall into the federal framework. But importantly, ACIP has noted, that they are not planning to fully finalize the phases until there is an authorized vaccine, understanding that there may be important information on, what populations are indicated for particular vaccines that could impact their final recommendations. But states are moving forward, based on these assumptions with their own planning to kind of further delineate how they may prioritize within these phases, understanding particularly initially that there'll be limited doses. And so just with a very quick scan of some of the plans that have come out since Friday, I think there's definitely, alignment with what the federal government has put forward in terms of phases and what states are planning. But I think there's still some needed guidance on kind of subcategories from the feds, and states are in their initial plans, at least, approaching it a little bit differently. And so I think as we gather the plans across the states and do some analyses, there'll be some good information there to understand, exactly how states are thinking about within these broader categories, specifically honing down on subcategories. And I will say that states are also, in every plan that I've seen, setting up some form of committee or work group or structure to work through these questions, bringing in, partners across the spectrum and working through some of these really challenging issues around ethics and equity. So that was definitely a key theme. Provider enrollment and onboarding, another big area for states. I think not one where we've heard a ton of challenges right now. I think states are moving forward with, enrolling and onboarding providers to be able to administer vaccines. And the real question will come around training and what that looks like, given some of the, significant challenges that are expected around storage and handling of certain vaccines, as well as administration and tracking. We have heard some confusion about enrollment in vaccines for children versus enrollment as a provider who can administer COVID-19 vaccines in certain states. And I think there's an appetite for just some clarity and guidance from CDC on that, in that you don't need to be a VFC provider to be a COVID-19 vaccine provider. So hopefully that will kind of be sorted out in the coming weeks, but that was just one area where we've heard a little bit of confusion. Distribution and supply chain, just just a couple of things to note here. There's obviously a lot of issues to work through on the distribution and supply side, which is probably not news to anyone on the line, but I think the cold chain requirements for certain vaccines really rises to the top in what we've heard from states and what they're working through, particularly the ultra low cold storage, and specifically the fact that those doses will be shipped likely in no lower than, I think, 975 dose increments. And that then presents additional challenges around, how you potentially may need to break those down, getting them to rural areas that don't need, a certain level of supply for specific providers. All of those kind of challenges, the cold chain storage, have really been emphasized with the states we've engaged with. And new information seems to kind of be coming out slowly about what these specifications will entail. So things like the fact that dry ice may need to be replaced immediately if it's not used within 24 hours. You may have to use special gloves, and other considerations kind of keep coming to the fore and adding additional questions around how this all will work together. And it kind of harkens back to that training piece with the providers and making sure, everyone has the information and resources that they need to execute on that. And then a couple other things just to know, as states are thinking about mass vaccination, really working through questions around maintaining social distancing and proper infection control, things for certain states, what may or may not work in the winter months with things like drive-through or mobile clinics. If there's a lot of snow, some of those just kind of really practical considerations around how these models for mass vaccination will play out are definitely a few areas we've heard from states. And then lastly, I would note long-term care facilities has come up in a number of conversations, and understanding that, pharmacies will be working with long-term care facilities, but a lot of questions, I think, still on the state side around, how the vaccine is getting there, who these facilities will be reporting to, how states can ensure they have the right information to be able to monitor and track what's happening. All of those questions are very much top of mind. And then I know I'm probably getting close to time, but just a couple of final things to note. Data and IT infrastructure, I know I referenced a moment ago, but I think this is really a key area where additional information is needed. There's a lot of questions around how kind of everything is going to flow together in terms of information that's reported to the feds, what's shared back with states, what essentially is kind of the data sharing flow. I think there's still not a ton of clarity on exactly how that's going to work. And specifically some questions and concerns around personally identifiable information. So as it's proposed now, the states would be expected to share PII with the CDC. And this is really, there's no precedent for this. It's really sort of the first time that type of information is being requested out of the state systems. So I think we've definitely heard questions from states in that area, and what some of the workarounds may be there to ensure, protection of information. And then state systems, so the state IIS or immunization information systems versus other systems for administration and tracking of vaccines has been definitely a question that's come up. And I think what we've heard is that a majority of states plan on using their IIS. There will be some that have indicated that they're interested in the federal vaccine administration management system, or VAMS, or other systems to either fill gaps or to simply use those in place of their IIS. But I think the majority, as we've heard, will be using their IIS. And then I think, again, it just comes back to how that flow is going to work across all of the different entities. And then lastly, I'll end with communications. I'll come back to that as being, again, something we heard in our meeting as really, really important and an area that states are still trying to work through how to structure messaging and identify the right messengers. I'll end there. Thank you.
Thank you so much, Kate. Really, really helpful. Sparked a lot of questions, but we'll wait till the end to ask questions. Right now, I'd like to introduce Dr. Jennifer Dillaha from the state of Arkansas to give us a perspective from a state who had to write a plan and submit it to CDC. She is a public health physician and the medical director for immunizations at the Arkansas Department of Public Health. And she also has focused a lot on health literacy, which is really helpful. I mean, if you could imagine the most perfect person who would be in charge at the state level, she's got an expertise in health literacy. She has a subspecialty in infectious diseases and in geriatric medicine. So she's well qualified. She's also an assistant professor at the University of Arkansas Medical Sciences Colleges of Public Health and the College of Medicine. So Dr. Dillaha, I will turn it over to you.
Unmute.
Oh, there you go.
Share my video.
There you go.
Well, I still can't. Okay, now I can start my video. Great. Well, thank you so much for having me today. As you know, we're all dealing with a pandemic. And one thing that Chris didn't mention is that I was also named the state epidemiologist in March. So I have a very full plate. And so to come up with a state plan for COVID vaccination was a challenge, just simply because of the time constraints that are involved. So we pulled together a team and we hired a special projects person to help us oversee the plan pulling together. Our immunization program established an internal work group of all the key players, and even within the health department, and that's a challenge because we're a large agency. In Arkansas, we have a centralized health department, which means that we do not have independent local and county health departments, but the state operates at least one local health unit in all of Arkansas's 75 counties. So that means there are about 94 local health units. So our plan was comprehensive for the state. We did not, we're not in a position to having to collaborate with independent health agencies. But you know, we found that we needed to catch up with our emergency preparedness folks and the previous flu pandemic plans and review those things and come together as a team to write the plan that we submitted on Friday. In addition, we established a external stakeholders group, and what we did for that is we built upon the foundations that we had already established with the State Immunization Coalition, Immunize Arkansas. We had already a flu prevention work group, and we had already begun to use that work group to help prepare for COVID vaccination even before the playbook was made available. So that group has become our COVID prevention work group, and we're inviting more and more people to the table. We meet at noon on Fridays via Zoom to make sure that everyone has the latest up-to-date information as possible, and then also to have an opportunity for people to ask questions and give input. A third group that we have established is based on the Arkansas Vaccine Medical Advisory Committee. This group has been in existence for probably 15 years or more. It was originally established as a group of medical experts between the Arkansas Department of Health and Arkansas Children's Hospital to provide medical expertise and recommendations when needed to the Secretary of Health in Arkansas. And so what we did with this group is that we established a subcommittee of members of the larger Vaccine Medical Advisory Committee, and also included an ethicist to help us look at prioritizations in Arkansas and how we would recommend priority groups for initial vaccine doses when we expect that the number of doses to be limited. We want to use the National Academies of Medicine framework, but we also want to provide direction based on the ACIP recommendations when finally they are available. In terms of how we would specifically apply them to Arkansas, they would make recommendations to the Secretary of Health for how the vaccine would be prioritized in our state, given our populations, the critical infrastructure employees, important industries, as well as the specific epidemiology of the pandemic in our state. And we have finally plans to establish an additional group, and that is an overall communications group, because the communications needed for COVID-19 vaccination is bigger than just the health department's Office of Communications. We're going to need to engage a wide variety of partners to do outreach. We have special populations in Arkansas that include, of course, the Latino population and our Black population, but we have a very large population of Marshallese in our state. And we want to make sure that they have the information they need regarding the vaccine. And of course, we'll need to address some of the reluctance on many people to engage in getting the vaccine because of the concerns of safety, and as well as just general information about if you do want to get vaccinated, where do you go and who can vaccinate you. So those are important considerations that we put together in our plan. We are one of the states, of course, that is using our state immunization information system. It's the Envision project, which we call WebIZ. And so we're wanting to make sure that it has the capabilities to do the reporting. And we also want to be able to easily track those providers of vaccinations who have enrolled in the COVID vaccination program. So we're working with Envision to use a REDCap online portal survey, so then that can be imported into WebIZ. So there's challenges like that, and we have made sure that the plan that we have written and made available is marked draft, because we want people to know that this is a work in progress. And of course, there are so many unknowns still and so many processes yet to be developed that really we're kind of presenting this as a plan to plan when we have more information. The Arkansas Freedom of Information laws are written so that we may not release this plan. So it has already gone to the press. It went to the press on Friday, according to Freedom of Information requests. So what we would like to do is we're going to go ahead and make it available on our website, and we will make it possible for people to send us input and comments on our plan. We're a small state, and we think that people being able to review the plan, make comments, give input in the planning process will go a long way toward helping people have buy-in and familiarity with the plan, and it will help us to understand the points of communication or misinformation or confusion that we need to address in our state. So there's a lot going on. We still have a lot of work to do, and a lot of the work is going to be around now, identifying our populations, our counts, all of the work that needs to be done to position ourselves to be able to track who's been vaccinated and who not, And then the coordination that we'll need to do within the state with regard to the Department of Defense and the efforts that were announced on Friday for Walgreens and CVS to potentially vaccinate long-term care facilities. So there's a lot of moving parts and coordination that needs to be done. But we're game, and we're looking forward to having the vaccine one day because we really need it. So I'm going to stop now and see if anybody has questions, or I'm not sure how you wanted to do the questions.
Great. Thank you so much. Thanks for taking time out of your busy schedule. So I'm going to have our next speaker, and then we'll take questions after that. Our next speaker is Blaire Bryant. She is the Associate Legislative Director for Health at the National Association of Counties. So she's going to give us the local perspective. She works with county officials across the nation and helps set NACO's priorities on all things health policy and public health. She has a BA from the University of Maryland and a master's degree also from the University of Maryland. So we're really happy to have you here today, Blaire. And Blaire has some slides. And so she is going to go ahead and share her screen.
Okay, I don't think that I can do it from my end. It's saying screen sharing is disabled.
Hold on one second. I think we have you as a co-host now. Let's see. Okay, well, if worse comes to worse, I can share my screen.
Oh, it popped up for me. So
Okay, terrific.
I'm gonna go ahead and share this.
Yay. Okay, great.
All right. Oops. Alrighty. Thank you so much for that introduction. Again, my name is Blaire Bryant, and I work on health policy at the National Association of Counties. Before I jump into my remarks, I really just wanted to use this opportunity to talk about the ways in which counties can be a partner to states and other jurisdictions as they take on their planning and implementation efforts for COVID-19 vaccine. So to give you guys some background on who NACO is and what we do, NACO is the voice for America's 3,069 counties. And one of the ways in which we advocate on behalf of counties is through intergovernmental partnerships with the states and the federal government. So these partnerships ensure that counties have the resources they need to provide services to residents, and they are critically important in times of crisis such as this. So that is our role at NACO. And in the same vein, I wanted to backtrack and provide a little information on how counties are assisting with public health and the role that they play in the public health infrastructure. So counties are involved in nearly every aspect of the local public health structure, whether it's our operation of health departments, local health departments, our support of local hospitals, our role in nursing homes and nursing facilities, or our contributions to the Medicaid program. So nationally, counties contribute to the non-federal share of Medicaid in 26 states, in addition to administering Medicaid services to the uninsured and medically indigent. So this is an important role that we play at the local level in assisting our states with providing healthcare and public health services to residents. So naturally, counties have been a critical partner in COVID-19 mitigation, whether it's investments in PPE or standing up testing centers and mobile health units, leading contact tracing efforts, or through the formation of some collaborative intergovernmental partnerships that helped with planning and resource sharing on the local level. So to provide some concrete examples of these partnerships, I just wanted to give an overview of some examples of the COVID-19 strike teams that have been formed across the nation since the beginning of the pandemic, and the importance of these strike teams and how they helped with COVID-19 mitigation efforts. So first, one of the biggest ways in which we've seen COVID-19 strike teams be effective in their work is in nursing homes. As you all know, nursing homes have been hit particularly hard by the COVID-19 pandemic, and strike teams have been an effective model in attacking virus transmission in these facilities. So one perfect example of this is in North Carolina in the Cherry Springs nursing home. They established a nursing home strike team that was based in the county, but also with assistance from state medical professionals as well as emergency response professionals. And they came in and they helped to isolate patients with COVID-19. They also helped to relieve staff that had been infected by COVID-19 and kind of replace some of that personnel that was lost, as well as helping to train staff on the importance of properly wearing PPE and how to remove PPE. So another good example of COVID-19 strike teams we saw in Florida, and this was a little bit different of a structure than what we saw in North Carolina, but in Orange County, they teamed up with their state Department of Health to ensure compliance for local facilities with regards to COVID-19 restrictions and proper, really proper compliance with restrictions for safety. So the strike team was made up of both county officials as well as state Department of Health officials. So that was an interesting way in which states and counties were partnering together on those efforts. And then lastly, in California, the Central Valley Strike Team and testing and tracing subgrantees was an example of how states and counties can share resources. So the Central Valley was especially hard hit by COVID-19, and Governor Newsom actually allocated about $53 million of the almost $500 million that the state received from the CDC directly to the Central Valley for testing protocol, quarantine protocol, as well as general mitigation strategies. And that was an important way in which states can subgrant some of the federal funds that they get to local health departments and local entities to assist with their mitigation efforts. The idea and the concept of the strike team used in the Central Valley was actually based on the success of a rural county in California that they had done this model with on a smaller level, and seeing how effective that was in containing the virus. They decided to do it on a multi-county level in this particular area in California that had been hard hit. So in addition to the sharing of funds, the strike team came in, much like we saw in North Carolina, and provided additional personnel as well as those additional resources that were federally funded. So despite the benefits of these strike teams, there have been some ongoing challenges seen at the local level with regards to responding to COVID-19. And I wanted to highlight these because these are the same issues that we're going to see as we move forward in vaccination planning efforts, and issues that should be incorporated in our thoughts about how we're going to implement a vaccine strategy. So one of the biggest things I think that has been an ongoing challenge is the persistent lack of critical supply and PPE shortages. So this is something that will be an ongoing challenge as we think about how our entities that are going to be distributing the vaccine, if they have enough PPE, if they're adhering to social distancing protocols, because it's kind of a unique situation that we are administering a vaccine in the midst of and still dealing with the pandemic. So we still have those protocols to maintain and still have to protect our frontline workers while also working to increase vaccine uptake. So In addition to that, public health personnel deficiencies have been an ongoing problem even before the COVID-19 pandemic. The public health workforce has been shrinking essentially over the past couple of years due to infrastructure issues and underfunding, chronic underfunding of local health departments. So we've especially seen a lot of personnel issues during the COVID-19 pandemic as personnel has been shifted from one task to the other, or it's just simply a loss of personnel just to budget cuts and shortfalls. So in addition to that, there's been some inconsistencies in testing reporting. This is something unique to counties and local health departments that we're seeing, is that maybe entities, private labs, and entities that are administering tests aren't always reporting back those results to the local health departments, which is an issue that they faced in trying to get a comprehensive picture of testing on the local level, at the county level. And then I wanted to mention revenue shortfalls and budgetary challenges. This is an important issue to think about as we think about vaccine strategies. Revenue shortfalls and budgetary challenges are not only going to impact the local workforce, but they're going to impact our enrollment in Medicaid, because as people lose their jobs, they also lose their health insurance. So that means the number of uninsured or underinsured will go up. This is an important thing to think about as we think about individuals with access to healthcare and who's going to be accessing the vaccine, and if they can afford COVID-19 treatment and vaccines. So in that, I wanted to plug that NACO has been tracking jobs reports, the national jobs reports, and then analyzing it and talking about the local impact as well. And I will say that national trends aren't reflective of what's happening at the local level. And we have seen that counties are reporting continued job loss, despite some increases in the jobs report as of recently. So moving into the county role in COVID-19 vaccine planning, counties, one second. So I actually did an analysis. The playbook has been mentioned a couple times by some of the other speakers, and we did do an analysis that talked about the county role in vaccine planning and distribution. And I'm happy to drop the link to that in our chat, but I also provide the link to our resource page at the end of my presentation. So wanted to just plug that as well. But moving into the county role in COVID-19 vaccine planning, I think that given all that I've said about the county role in public health delivery, the county will play an integral role in not only the planning, but in the distribution process of vaccines. So many of these stakeholder examples that the CDC mentioned in that playbook that should be included in the external implementation committee are in fact county owned and operated. So this kind of goes back to one of my first slides about all of the ways in which counties have their hands in local public health. A lot of those entities were listed in the playbook as entities that should be included in the external planning committees. So counties will have a role in not only recruiting these entities to be a part of that committee, but providing oversight of the agencies as well. And then secondly, as direct service providers, counties have direct access to populations deemed as critical, or the priority populations deemed by the ACIP, such as nursing home residents, residents in remote and rural areas, and populations of color. So during the planning phases, counties can be polling these critical population groups and stakeholders and ensuring that they have all the necessary considerations for these populations are being made and their voices are being heard in the planning process. And then lastly, the biggest role that county officials will play in this process is being a trusted voice and communicating vaccination plans and updates to residents in a factually sound manner that instills confidence. A number of the other speakers mentioned the importance of vaccine confidence, and I think counties as public figures, as well as state officials as public figures, are used to being playing the role of the trusted voice. And this process will be no different for that. So moving towards distribution, our role in the distribution process will be equally important. First, leveraging local expertise. According to some profile data by the National Association of County and City Health Officials, most local health departments already provide direct immunization services. So these departments have a solid foundation in expertise in planning and administering vaccine and immunization programs. So counties should be ensuring that this expertise is being leveraged in the planning process and in the execution committees as well. So I would encourage states to include local health departments who already, are used to planning for the flu vaccine or MMR vaccine programs, to include their voice in the planning process, in the execution process as well. And then secondly, advocating for necessary resources. A survey conducted in June of this year by NACCHO revealed that immunization programs in local health departments were most impacted by COVID-19 through, as I mentioned before, the redirection of funding and the loss of staff. So this correlates to the personnel shortages I mentioned earlier. The findings also suggested that while the majority of local health departments are prepared to give COVID-19 vaccines, they have stated that they will need additional resources to do so. So again, just making sure that our local health departments, which will be possibly an entity that's distributing the vaccine, has the personnel, not only the resources, meaning the vaccine, but also the personnel to administer the vaccine as well. And then lastly, again, county officials will play an invaluable role in increasing vaccine confidence and uptake as public figures, as I mentioned before. So this is kind of the list of unknowns that have already been stated by other speakers as to things that will impact our vaccine planning efforts, as well as our distribution efforts, that we just don't have any information on right now. So we don't know when or how long the FDA approval process will take. And also once the vaccines have finished the final stage of clinical development, we don't know yet who the vaccine will be most effective for, which will play into the role of what are the critical populations and priority populations that will receive the vaccine first. So right now we're kind of in a holding state and kind of just making sure we have all options considered in our planning efforts for priority and critical populations. And then lastly, federal planning and implementation grant funding is another source of unknown, especially for counties, because we have traditionally not been direct recipients of CDC planning grants. That's usually at the state level, or it is allocated to very large local public health departments. So some of our counties may get it. So like a Cook County or a county in California may get it, but maybe not some of the smaller counties. So just making sure that some of those funds are trickling down to the local level is critically important. And then, as I mentioned here, you can find more resources on the county response to COVID-19 on our resource page, and we will be upscanning a page specifically for vaccines and vaccine planning. So with that, I will go ahead and end and turn it back over to Krista for questions.
Thank you. Thank you so much, Blaire. So we're gonna open it up for questions, but I'm gonna take the moderator role here and ask the first one. Kate, you mentioned that there were other allocation factors that states wanted to see beyond just the population-based formula. Can you tell us a little bit more about what states want to see related to allocation?
Sure. So we don't have, a specific list from states, but I think they're just wanting additional clarity on, will there be consideration around the level of critical populations in each state? So thinking about phase one and the level of individuals, that will be sort of necessary to vaccinate in each state will be different. And thinking about that on top of, we've heard some questions around, will there be consideration on where, outbreaks are happening? Just what will some of the additional factors be that the federal government is considering around the allocations versus just, sort of the state's population size, which is the only thing I think to date that's been communicated kind of in public documents. So.
Okay. Thank you. Dr. Dillaha, I'm wondering what your direct communication is like with CDC. Are they holding calls for state immunization directors? Are you able to reach out to them and reach people there for help if you need it?
Yes, we have weekly calls with our project officer as well as weekly planning calls with a number of other states. And we've had very good communication with our project officers and folks at the CDC. Of course, there's things that they don't know that we want them to know and be able to tell us. But, let me ask too about the allocation questions. We have questions like, there are some things that the Department of Defense is going to handle, but there's some gray areas. For instance, for the military in Arkansas, including the National Guard, will that include their families or not? There's some things like that we don't know.
That would make sense given that they're all in close proximity to each other. And then Blaire, have you noticed from your members that they're building on existing committees that they already had with the state level? So Dr. Dillaha was saying, they had this flu vaccine committee that they were able to sort of utilize in talking about COVID. Have your members had existing kind of infrastructure relationships with the state level that they've been able to commandeer for this purpose?
Yes, some of them, absolutely. So I was on a call last week with some of our county executives, and someone mentioned that they had used a partnership that was previously used for H1N1, for the H1N1 vaccine, and kind of leveraged that partnership and kind of refreshed it for the planning efforts around a COVID-19 vaccine. And I think that's a very smart strategy, as well as just counties also have committees that they're using for their regular flu vaccine program planning. So they're leveraging that as well.
Okay, great. Dr. Dillaha, on the IT infrastructure piece, are you pretty confident that the vaccinators in the first phase will be able to enter all the necessary information that CDC needs into the public health registry? And do you have any of the problems that we've heard about with personal health, identifiable health information being entered into that registry?
So one of the situations we are facing is our use of WebIZ, our state immunization information system. And we have providers already onboarded so that when they enter the information to their electronic medical record, it goes into the registry. There may be new vaccinators who want to participate in the COVID vaccination program that we wouldn't have time to onboard them in that way. So that's one of the questions about how can they efficiently, quickly enter that information into WebIZ. With regard to the data and the PII and all of those questions, kind of jury's still out. We're still wanting better clarity on that and what that means and what the implications are.
Kate and Blaire, are you receiving a lot of questions about payment? I know that here at Serona, we've been fielding a lot of questions about how providers are going to get paid for the administration of the vaccine. I think most people know that the vaccine has been paid for, but there's a lot of costs that go with storing and all of the reporting requirements, getting people, in to get the vaccines, et cetera. Are you getting questions about that? And do you feel like you're able to answer them? I'll start with Kate.
Yeah, it's definitely come up, and would be curious what others have to say too. But I think the sense is, the doses are paid for, at least a specified amount of them, through the federal contracts, and administration fees would be paid by the various insurers, including state Medicaid and Medicare. And I think there's ongoing conversations with payers about ensuring that there's no copay for individuals. There's also been some comments publicly about a fund for uninsured individuals at the federal level, but very little clarity on that and exactly how that's going to work. So I think that really remains an area of outstanding question of how uninsured individuals will be dealt with. And just one thing that we've heard from some states is around the administration fee, will there be sort of an allowable charge, or what will that fee be? And so that's kind of a remaining question we've heard.
Okay.
Yeah, I'd say the same as Kate. It's a lot of unknowns as far as how providers will get payment for administering the vaccine. We would assume it would be something similar to the way in which they've been doing testing, but would hate to really harp on that assumption. But definitely looking to CDC for more clarity. Well, not the CDC, HHS and CMS, for more clarity for particular Medicaid providers and how they'll get paid.
Great. So I'll end on a question for Dr. Dillaha. Given your expertise in health literacy, do you have any tips for other states and for counties and others listening to this webinar on how to talk to people about vaccines and make them feel more comfortable?
There are some tips particularly related to vaccinations. And one is, we know that the myths are important, but don't spend your time debunking the myths. The more you repeat them, the more they are believed. So instead, focus on communicating the truth, the safety and the efficacy when those studies are appropriate, and make sure that you're able to create a trusting, a respectful, as well as a listening relationship, because people who are reluctant to vaccinate will trust people over time if you can maintain the relationship.
Great, thank you. Well, thank you so much to all of our panelists. We really appreciate it. This is such an important issue, and state and local governments have such a huge role to play. And so many of us are happy to hear from you and how it's going. We are having our next webinar on IT infrastructure. So hopefully folks will tune in for that. And thank you again for taking valuable time to be with us today.
So glad
Take care.
to be here.
Thank you.
Thank you.